Hello everyone, my name is Young. I'm from University of Medicine and Pharmacy at Ho Chi Minh City of Vietnam. Today I am very happy to be here and present you my work about trial change signatures to predict the chemotherapy responses in gastric cancer patients. First one, I want to go to the background. As you may know, gastric cancer remains the global health challenge, and despite the advancement in therapy, many patients still experience recurrence after chemotherapy. This highlights the need for more reliable biomarker to guide the treatment decision. Traditional indicator and serum tumor marker show limitation. In recent years, gene expression signature, which means a pattern of expression, uh, providing involving many genes have shown great potential to predict the treatment outcome and in many and disease progression in previous study. So in our study here, we aim to develop and validate gene signature that can stratify gastric cancer patients into groups with different risks of recurrence. Uh, After receiving fluoropyrimidine and platinum chemotherapy, which is the most widely used regimen. So the method we use is we utilize the several public available gastric cancer patient data sets from gene expression omnibus. From these, we select patients who have received specific chemotherapy that we want, which is the CF, the fluoropyrimidine and chemo and platinum. Our analysis involve follow three steps. The first one, identification, the more informative genes. The first gene set is genes that differentially express between the responsive and non-responsive gastric cancer patient. Uh, and two other gene set is the genes that associate with disease-free survival by using univariate analysis. And then we use the Venn diagram to select 12 common trees between the three gene sets, which is we represent for both characteristics. And then we continue to the step two. We use the training data core and we apply the principal component analysis to investigate to investigate to integrate the expression level of trio 12 gene into a single predictive index for each patient. And based on this, and patient will classify as low high risk or low risk depending whether their predictive index were below or above the median value of the core. The final step is validation, and we and to improve the robustness, we use the superfactor machine and classifier and validate the model with least one out cross validation. Predictive accuracy was assessed by using the Kaplan-Meier disease-free survival curve, log-rank test, and cost regression analysis. And the result you can see here, the table 1 display for the clinical characteristic of the patient in each selected data set. The table 2 present here 12 common genes among three gene set using the Venn diagram, with each uh, gene that below that have the specific function or even that their function is not under is not determined. determined. When we in the training cohort and the training cohort is the trial gene signature significantly separate low and high gene high risk group, and similarly in the validation data set, the model remain effective with the and both uh and both use and both univariate and multivariate proportional hazard regression show that G signature was enough. signature is an independent prognostic factor. And when we apply to the clinical subgroup, the signature retain predictive value in the first one in the stage 4, which is the stage that have distant metastasis and the diffuse type of tumor cancer in the middle or the distal location in the tumor that's at the middle or distal location of the stomach, or in the subgroup that have the patient above below 65 age. In conclusion, we developed and validate a propoundness of the 12 gene signature that can predict chemotherapy response and recurrent risk in gastric cancer. By interpreting machine learning and with large-scale transcriptome data, this study illustrates how AI-driven can enhance biomarker discovery and contribute to more personalized treatment strategy. Our findings highlight the potential of gene signature to support early risk stratification, both chemotherapy monitoring and individualized clinical decision making. However, uh, the performance were limited in certain subgroups, so such as in early stage disease and another type of tumor, uh, another location of tumor. So we suggest that in the future model should integrate more details such as molecular, clinical, and imaging feature for broader applicability. Uh, this is the end of my presentation. Thank you so much for your attention.